go for it.
Starting in 3, 2,
And I'll meet everyone.
1. Please start, sir. We are live.
Great. Hello, everyone, and thank you for joining us for this inaugural Yogi IBD session. This is our first truly educational webinar that is global from the Young Global IBD Group, and it would not be possible without the infrastructure that was established by Dr. Ignacio, who is joining us shortly from Spain. We also welcome Dr. Aline Sharabadi, who's one of the founders of Yogi. But again, I would like to thank everyone who's on this meeting and especially our guests, which I'll let Dr. Farouk welcome them in due time. We will start this session with a 30-minute presentation by two of our Yogi presenters. And then after that, we have esteemed guests who will be introduced, and we will have some Q&A session. And while this is happening, all of you are able to send questions on the streaming webinar source, and we will receive those questions. And if we have time, we will get to them. And hopefully, they'll be the questions that we are asking as well. So with that, I will give it to Ayman. Ayman is one of my dear friends who I've known for a few years now. She's a rising star in gastroenterology in the USA, and she is currently a third-year GI fellow in Orlando, Florida. And we are excited to see that she has decided to be on the IBD path. So I'll give it to you, Ayman.
Thank you, Joseph. He is a friend and a mentor, and I'm excited that I can be part of this educational session today. Thank you, everybody, for joining us for today's session. We're very fortunate to have an experienced panel and presenters from around the globe with us. Let me briefly introduce our presenters for today's session. We have Dr. Siddharth Harindranath, who is an assistant professor of gastroenterology at King Edward Memorial Hospital in Mumbai in India. He has completed his GI training in 2022, along with a dedicated one-year fellowship in inflammatory bowel disease in 2024. Our other presenter is Dr. Rana Ismail. She is an assistant lecturer of gastroenterology and hepatology at Fayoum University in Egypt. So our goal today is not to only hear from our presenters and experts, but also to spark dialogue. So please think about the questions and reflections that you might have, and we will open the platform at the end. I'll give it to our presenters now.
Yeah, thank you for that introduction. And at the outset, I would like to thank the Yogi IBD team, Dr. Joseph, Professor Ignacio, for this opportunity. So without further delay, we will move on to our topic, which is the battle of innovation and resources. Specifically, we will be discussing on IL-12, IL-23 inhibitors, comparing P19 and P40 inhibitors. Next slide, please. So over the next 30 minutes, my colleague, Dr. Rana, and I plan to take you through, discussing new therapy approvals that are happening in the IBD space, compare P19 and P40 inhibitors with respect to their structures, what is the clinical trial data, and what is the real-world evidence, showcase data on recently approved P40 biosimilars, and data comparing P19 to P40. And we'd like to close off the talk by providing some unique perspective from both our countries on this topic. Next slide. Next slide, please. Yeah, thank you. This slide is quite familiar with everyone, I think, and this just shows that the recent burgeoning of therapies that are happening in the IBD space. We are right now in the era of advanced therapies with a whole host of biologicals and small molecule inhibitors entering the foray. Next slide. This slide just shows the recently approved P19 as well as P40 inhibitors, and you can see that most of 2024 and 2025 were year of approval of all these new agents, with Tremfya, that is guselkumab, just recently receiving approval for ulcerative colitis just this last week. Next slide. So let us talk about the structure. What is different between P19 and P40 inhibitors? So both of them inhibit IL-23 as well as IL-23 inhibitors as well as IL-12. And structurally, when you look at IL-23, it is a heterodimer made up of P19 as well as P40 subunits, with the P19 subunit unique to the IL-23, whereas P40 being shared by both the cytokines. And subsequently, risankizumab, guselkumab, and mirikizumab, which are selective P19 inhibitors, inhibit only IL-23, whereas ustekinumab inhibits both IL-23 as well as IL-12. Guselkumab has an additional CD64 binding unit, so theoretically, it has a potential of a more potent IL-23 inhibition. Coming to the original drug, that is Stelara, approved for moderate to severe Crohn's disease as well as, next slide. Stelara, that is approved for ulcerative colitis as well as Crohn's disease, initially approved for plaque psoriasis as well as psoriatic arthritis. All the international guidelines suggest using it as for induction and maintenance of remission in moderate to severe Crohn's as well as ulcerative colitis, with none of them committing to whether it can be used as first or second line. Safety is more or less similar to the previous biologicals, including safety in pregnancy. Dosing, it has a weight-based induction dose, slightly different from what is used in psoriasis, and a subcutaneous 90 milligram, either 8-weekly dose or 12-weekly for maintenance. And right now it is available in a single dose pre-filled syringe. Next slide. The efficacy and safety of this molecule, that is ustekinumab, comes from the Unity and IM Unity studies in Crohn's and Unify studies in ulcerative colitis, which show that a weight-based dose, that is 6 milligram per kilogram, achieved much better response with respect to clinical remission, clinical response, and endoscopic response. And a 8-weekly maintenance dose of 90 milligrams subcutaneously maintain those response rates. Next slide, please. So what is the data in perianal Crohn's, pouchitis? Perianal Crohn's disease, there are no dedicated randomized control trials. What we have is post hoc data from other RCTs and a recently prospective multi-center study from the GET8 cohort, which show that around 30 to 50% achieve clinical response or fistula improvement within 6 to 12 months. Although complete fistula healing rates are modest at the rate of 22 to 40%. Pouchitis, again, very high clinical response rate to the tune of 60 to 80%. But endoscopic response rate is modest, around 40%. But ustekinumab looks to be a more effective agent than vedolizumab and anti-TNF agents, particularly in those who have Crohn's-like disease of the pouch. Most of these patients, especially perianal disease, will require dose intensification to either 4-weekly or 6-weekly. And the encouraging fact is that 58% of them do regain clinical response after dose intensity. Next slide, please. Quickly about the recently approved P40 biosimilar. This is Tekima, and they recently approved for IBD. The approval data comes from phase 3 data for plaque psoriasis. You can see that the median PASI score, that is psoriasis activity severity index, was more or less, the mean PASI score was more or less similar between the originator molecule as well as the biosimilar. Next slide, please. Similar data for another biosimilar, that is Yesintek. Again, data based on plaque psoriasis. Next slide, please. And lastly, Otulfi, which is recently receiving approval. So all these three biosimilars have received approval based on plaque psoriasis, which is what is usual for biosimilars. They just need to get approval for one approved indication, and they can be extrapolated to other conditions with similar pathophysiology. Next slide, please.
We have three members of interleukin-23b19's inhibitor, risankizumab, mirikizumab, and kozelkumab. All of them are approved for moderate to severe CD and UC patients. Given the favorable safety profile, B19 can be used in pregnancy, and as other biological treatments, TB and viral infection should be excluded first, along with monitoring liver function tests and CBC. And this table summarizes induction and maintenance doses of the three members of B19's inhibitor for your reference. And generally speaking, induction doses are given intravenously at 0, 4, 8 weeks interval, while maintenance doses are given subcutaneously, with exception that Tremfya recently can be given subcutaneously in induction doses in UC and CD patients. Next slide, please. This table summarizes the trials that studied 3B19's inhibitor in CD patients, which depended mainly on treat-through study design, with nearly half of participants were biologic experienced. Next slide, please. Meanwhile, trials that involved UC patients had two phases: induction phase followed by re-randomization of responders before maintenance phase. Next slide, please. Sequence trial is an open-label randomized clinical trial which compared between risankizumab and the standard doses of ustekinumab as a second line in patients with CD after failure of anti-TNFs. Risankizumab showed statistically significant better performance in terms of achieving clinical remission, endoscopic response, and remission. Of note, this trial is non-blinded, and the number of patients from ustekinumab group who dropped from the study was 3 times those who discontinued treatment from Risa group due to any reason. While higher percentage of patients on Risa group has any adverse events, this goes with that risankizumab is more effective than ustekinumab. Next slide, please. Here, VIVID-1 was a phase 3 double-blinded, placebo-controlled randomized clinical trial with read-through design, where moderate to severe active biologic experienced or naive Crohn's disease patients were randomly assigned into one of 3 groups: mirikizumab, ustekinumab, or placebo. Mirikizumab has a statistically significant better performance in maintaining clinical remission and endoscopic remission compared with ustekinumab. Next slide, please. In Galaxy 2-3, which is a double-blind randomized clinical trial, again with read-through design, included biologic-exposed CD patients who were randomized into 3 groups: kozelkumab induction dose followed by either maintenance dose of 100 milligrams every 8 weeks or 200 milligrams every 4 weeks, and the third group received ustekinumab standard dose. The study showed that subcutaneous kozelkumab is statistically superior to ustekinumab in endoscopic response, especially with using higher maintenance doses. Next slide, please.
So we saw the data for clinical trials. What is the real world evidence? So this is studies comparing P19 and P40 inhibitors, a retrospective cohort study from a large TriNet US collaborative network of around 65 research centers, comparing 1,600 patients on risankizumab versus 3,000 patients on ustekinumab, who were subsequently propensity score matched. And they found that there is no difference in steroid use, number of hospitalizations, patients requiring surgery, emergency room visits, opioid use, switch to advanced therapy, or change in biomarkers. Next slide, please. Another large prospective study from the Spanish ENIDA registry of 800 Crohn's disease patients, predominantly bio-exposed, and 56% of the patients have achieved steroid-free clinical remission on risankizumab. And again, remission was more frequent in patients who did not receive ustekinumab previously. Long-term efficacy data available for 600 patients with a median follow-up of 7 months. And 60% of them maintained steroid-free clinical remission. And again, long-term remission rate being higher in patients who are not exposed to ustekinumab compared to those who were. Again, very few adverse events, with only 18 patients requiring to give up treatment. Next slide. So this is another retrospective single-center observational study of 36 Crohn's disease patients, 2/3 of them having failed 2 or more biologicals in the past, and half of them who have received ustekinumab. And all of these patients showed a good response in terms of decrease in HBI scores, improvement in fecal calprotectin, and decrease in CRP levels, and overall relapse-free survival with very few adverse events. Next slide, please. We saw the data for Crohn's. What is the data for ulcerative colitis? There are no dedicated studies as of now. What we do have is a network meta-analysis, which showed that mirikizumab performed better, but had no statistical significance when compared to ustekinumab. And the recent ACG guideline admits this lack of data and provides no specific guidance on class switching when patients don't respond to ustekinumab. Next slide, please. This was recently presented in this year's ECHO, a retrospective cohort study of 40 patients, 23 starting induction dose at the beginning of the study. And after completion of the study, 80% of them achieved clinical remission. 60% had been previously treated with ustekinumab, and 1/3 experienced a relapse, of which majority, that is 80%, had prior therapy with ustekinumab group. Next slide, please. But is there data for P19 inhibitors in perianal disease? Not yet, but the Fusion CD trial studying guselkumab in patients with fistulizing perianal Crohn's disease would be interesting to see. Next slide.
Okay, so B19 actually showed success after B40 failure. In VIVID-2, which is a long-term extension study where patients with CIS CD score above 7 divided into 2 groups, either endoscopic responders or non-responders. Non-responders was re-induced and then received maintenance doses of mirikizumab, while responders continued maintenance doses of mirikizumab. As seen here, clinical and endoscopic remission were achieved among responders and non-responders group. However, higher rates are seen among responders group. Next slide, please. This is a retrospective study revealing real-world data on using risankizumab after ustekinumab failure in CD patients, and the study included 52 patients who failed ustekinumab and showed significant improvement of HBI, fecal calprotectin, and albumin within 3 months. Next slide, please. Another prospective study on CD patients showed that higher rates of ustekinumab-naive patients achieved steroid-free clinical remission compared with ustekinumab-experienced group. Both of these studies didn't describe objective outcomes as endoscopic or histologic response. Next slide, please. Another retrospective study focused on using mirikizumab after ustekinumab failure in UC patients and showed significant improvement regarding simple clinical colitis activity index and fecal calprotectin. And again, this study didn't describe objective outcomes. However, it's reported that no difference between number of advanced therapy and treatment response. Next slide, please. In VEGA trial, which studied effect of combination therapy versus monotherapy in biologic-naive patients with moderate to severe ulcerative colitis, combination therapy with guselkumab and golimumab is safe and superior to golimumab alone and achieved endoscopic and histologic remission. Next slide, please. Next slide. There are 2 other ongoing trials studying guselkumab with golimumab in ulcerative and CD patients with moderate to severe disease activity, and yet results are pending. Next slide, please. The annual cost of ustekinumab reached above $29,000 in 2021. Ustekinumab biosimilars are expected to reduce cost by at least 30%, with projected annual cost $21,000. And this table summarizes the cost of induction and maintenance doses of the 3 members of B19's inhibitor, which is generally higher than ustekinumab cost. Next slide, please.
So now we heard the data, the clinical trial and the real world evidence. What we'd like to show you is the unique perspective from both our countries, that is India and Egypt. On the left side, you can see the molecules, the advanced therapy molecules that are currently available in India. On the right, you can see Egypt. More or less similar with the exception of golimumab being available in Egypt. But what is interesting to see is that P19 inhibitors are not yet available, and we only have the P40 original molecule, that is ustekinumab yet. P40 biosimilars are on the horizon, but not yet available. Next slide, please. To show you what are the unique challenges that we face in India, just an overview of the healthcare system in India. 70% a rural population with limited access to basic diagnostic services like a colonoscopy. There is a lack of a state-wide health insurance scheme that the patients can avail. So most of our patients who are newly diagnosed ulcerative colitis and Crohn's end up receiving corticosteroids with or without immunomodulators. With those who are refractory or intolerant, only receiving anti-TNF, again with the use of immunomodulators, and very few patients now receiving vedolizumab and ustekinumab. Next slide. So some strategies we can work on is increasing rates of diagnosis, instituting early effective treatment, particularly in Crohn's disease, preventing complications like tuberculosis, and genotype testing before starting immunomodulators, working with what we have, that is an accelerated step-up approach, and patients who do end up receiving biologicals, maybe formulating an exit strategy for them, because most of these patients don't have the means to continue biologicals long-term. And way forward would be ideally establishing a national library registry with an electronic database, collaborating with other low and middle income countries to develop consensus guidelines. We do have one such now from thanks to ECHO, and developing a centralized healthcare system with universal health insurance. So currently our patients only get $5,000 per year that is approved for biologicals for inflammatory bowel disease. Next slide.
In Egypt, we face shortage of IBD-MDT teams and low availability of informative histopathological reports, which is needed on diagnosis and follow-up, in addition to lack of awareness about IBD among patients that lead to poor adherence to therapy, in addition to expensive medications. IBD care could be improved through encouraging IBD research, investing in development of MDT teams, train GI pathologists for more formal, informative histopathological reports, and encourage communication between GI physicians and pathologists, in addition to patient education. Thank you.
Well, thank you so much, Rana and Siddharth. This was a tour de force and an incredible summary on the data between P19 and P40s, as well as the limitations that we face in the world. And before we move forward, I wanted to check if Nacho has joined us. And if not, I'll let Ayman present our guest speakers who have been able to join us today.
All right. Thank you so much to our presenters. That was very insightful.
Y el campanario ahí, eso que hay ahí, ya está.
Okay.
Go ahead, Ayman.
I'm going to go ahead and introduce our fantastic panel of experts that have joined us today, and with their diverse perspective from around the globe. First, we have Dr. Patricia Kazan. She is a gastroenterologist and IBDologist at Flinders Medical Center and IBDSA in Adelaide, South Australia. She is passionate about clinical education and clinical research. Welcome, Dr. Patricia Kazan.
Thanks. Thank you very much. Thanks for having me tonight.
We have Dr. Mubuno Malambo. He is a lecturer in the Department of Medicine at the University of Zambia and the head of gastroenterology at the University Teaching Hospital, which is the biggest referral center in Lusaka, Zambia. He's actively involved in clinical care, medical education, and research in gastroenterology. In 2023, he was awarded the prestigious IOIBD Clinic Exchange Fellowship at AIIMS New Delhi, where he gained advanced training and exposure in inflammatory bowel disease management and research. Welcome, Dr. Malambo. Then we have Dr. Kwajo J.B. Ajanem Boateng. He is a gastroenterology fellow in training and head of the Internal Medicine Directorate in SDA Hospital, Kodaso, Ghana. I apologize if I didn't pronounce your name right, Dr. Boateng. And last but not the least, we have Dr. Maria Manuela Estevino. She's a gastroenterologist in Porto, Portugal, with a clinical and research focus in inflammatory bowel disease. She's an active member of Y-ECHO Committee of European Crohn's and Colitis Organization and serves on the scientific committee of Portuguese IBD Group. She also completed a visiting IBD research fellowship in Mount Sinai, New York, and serves as an associate director of Journal of Crohn's and Colitis Plus. Welcome to all our panelists.
Thank you.
Thank you.
All right. So I'm going to start with some questions, and then, like I said, we will open the platform for our audience. The first question I would direct towards Dr. Estevino and Dr. Malambo. And so from the data that has been presented, do you believe the structural differences in P19s and P40s give an advantage to P19s over P40 therapies?
So if you allow me to start, indeed, I do believe that currently we have both mechanistic and also like trial information that makes us believe that P90s may indeed be superior. In terms of mechanistic studies, we see that by sparing EL interleukin 12 pathway, this allows us to be more selective. And we do know from some animal studies and several in vitro studies that EL23 appears to have a much more relevant role in the setting of chronic inflammation, mainly when we think of IBD. And these mechanistic data then translated to clinical trial data, as we were just exposed to. We see that several trials show that these drugs are efficacious, and besides that, they do work in patients that were already exposed to, for example, ustekinumab, right? So this indeed makes sense when we look to our clinical practice. Of course, we still have a lot to see, and we are starting to have some real-world data, but it's not that abundant yet. But what we see here are very positive signs, I think.
Thank you, Manuela. Dr. Malambo hasn't joined yet, so I can fill in for him for this first question. I think that one more thing that people ask is whether guselkumab's additional CD64 binding capability has any additional value. I can only say that in animal models, mice particularly, there has been a signal, but we truly don't have in-human data to justify it. And a lot of the clinical trials differences between the drugs are currently just assumptions because we don't have P19 head-to-head, and they're different doses. So, well, we can't really comment on the CD64.
Yeah, fully agree. That's a very, very important topic to mention, because it's something that when we read things is something that they always like to highlight because it's a difference, even though we don't know what that really means in practice. And just saying, I think I haven't mentioned that when we look to studies, in vitro studies and mechanistic studies, we also see some signals why using P19 inhibitors after ustekinumab makes sense, because we see that there are some cells that are like evading apoptosis through because they keep IL-23 signaling working. So this is why we do see in clinical trials and in real world studies that this is a strategy that makes sense.
Thank you. We can move on to the next question.
All right, I'm gonna direct this question to everybody in the panel, and they can answer about this. And this is about the dose intensification of P40s. Have you used dose intensification in your practice? And how does the availability of P19 affect your decision? When do you pull the plug? And does cost make any difference in how you make your decision?
Patricia?
Yeah, sure. Look, yeah, definitely I did use P40 intensification in my clinical practice. I'm from Australia. Unfortunately, none of the P19s are available yet. We are trying very hard to get one of them, and there is a strategy in us for Australia. So usually a medication needs to be TGA approved, so approved by the Therapeutic Goods Administration, and then it needs to pass by the PBAC, which is the Pharmaceutical Benefit Advisory Committee. Guselkumab so far is, received like a green light. It's been strongly recommended, but that's on a as well on a cost minimization basis. So it's back to health economics. So we still don't have guselkumab or any other P19. So we only have the P40s, and when a patient has some signal of a response or a loss of response, I do go to dose intensification, whether by reinducing the patient with an IV dose or escalating, the interval of dosing to 4 weekly or 6 weekly. I do think if a patient is responding to a dose intensification, I take it at its full. So I will use it until the patient fails and then go back to P19 if I had it. But unfortunately, the medication isn't available so far, and I'm really desperate to have it in Australia, hoping for next year for guselkumab, so we can use it in patients who, because a lot of the time we exhaust all the available therapies, and we are always in desperate need for novel therapies, particularly for Crohn's disease. So I do use it. I do use dose intensification. It does work for a lot of patients. I know there have been some data, to compare IV reinduction versus subcut. I have, in my own clinical practice, I've had success with both strategies. I still have a lot of patients from previously on 4 weekly and 6 weekly ustekinumab, and they're doing quite well. In terms of biosimilar therapies, we only just had Stekima as of the 1st of August in Australia approved, and we've switched a lot of our patients. I work across the public and the private sector, and I think again it goes back to health economics. So if the medication is cheaper on the government, we did shift patients to the biosimilar medication, and we are hoping with the biosimilars arrival, the ustekinumab biosimilar, we would be able to hopefully get the P19. Again, it all goes back to the health economics. So hopefully, with having a lower cost medication, would give our patients access to P19s.
Thank you. Dr. Boatin?
So, in my practice, I think looking at the data presented, we are a bit far back because in terms of biologics, we only have the TNF. So we have infliximab and then adalimumab, but we don't have Vido. We don't have the small molecule Stofa, and we also don't have the P450s. So most of our patients are still at the level of the 5-ESAs. Then some are still on steroids, and some are still doing the azathioprine. Even for the infliximab, cost is the major issue. Some patients start and then they can't continue, and then we are stuck because now they've been exposed to biologics, and then we are eventually stuck with what next to do for them. So I think we had one patient who started he was quite young, 16. He had it for 3 years. He was infliximab exposed. He couldn't continue because of cost. Initially, they had to do a lot of donations to even get him to start and infliximab, and then due to UC, and then we had to use cyclosporin, which actually worked. So those are the options that we have available at our end.
Yeah, that is quite shocking in 2025 to have this much difference across the globe for patients who need care with IBD. So thank you for sharing that insight from Ghana. Manuela, do you like to comment, or would you like us to move to the next question?
I can say something. So my reality is quite similar to the one Patricia described. So right now in Portugal, we do have ustekinumab and P40 biosimilars that we have, and it's easily available. Regarding P19s, we can request them, but just as like special authorizations. When patients were refractory to all the other drugs, we can have access through things that here in Portugal we call like early access programs, in which you can ask for a specific patient that has been refractory to all the available therapies, and the patient can receive a P19, but just on that condition. And of course, the number of patients that can receive that medication is limited, because it's a program that is limited to I think it's 20 or something patients. It depends on the things they combine with pharma itself. But yes, it's very similar.
Right, I'm going to move on to the next question, and that's again for the panel, whoever wants to answer, is about biosimilars. People who have access to P40 biosimilars, how comfortable are you, and how comfortable are your patients in switching to biosimilars, and at what level, at the pharmacy level versus at a physician level, and do you support pharmacy level switch if that's something that's happening in your region?
Okay. So in Australia, it's mainly led by the physician and the IBD nurses. I work across a couple of big IBD units. And so we have a lot of the adalimumab biosimilars, obviously, on the market. We have 4 or 5 in Australia, and we are very comfortable with them. The ustekinumab biosimilar, as I just said, just came. So we've heavily started moving all of our patients to the Stekima. And I think it's based on a patient-to-patient approach. I'd always consent the patient and I say, look, we have this biosimilar available. It's basically, from what we know, it's got a comparable efficacy. The pharmacokinetics are similar. I'd explain to the patient it's got the same safety, the same immunogenicity profile. I am comfortable. Is that okay if we give it a try? And one better thing with the ustekinumab, the Stelara, or the patient with Crohn's disease, they had to have the two syringes and the 45 milligrams. The Stekama is only a 90 milligram, only one subcut pen, so they don't have the hassle. So it's a bit easier actually for patient to inject the Stekima. So far, and we have it only so far for 6 weeks. I haven't had much complaints. One patient called back the very next day complaining of severe constipation. Is it really the biosimilar? Is it a nocebo effect? I mean, sometimes you can predict which patient's going to have what. So I've shifted her back to Stelara and just monitoring. Sometimes I know some of the patients are quite anxious. It takes time. So they've just started on ustekinumab. They just finished the first 6-month cycle. I'm a bit more patient. Personally, I'm quite comfortable, with shifting, and I just take it on a patient-to-patient basis. It's case by case.
Thank you. If anybody else would like to comment on this. All right. I see that Dr. Molambo has joined us, so I'm going to introduce him again, and then I will give him the platform to comment on the topic. So Dr. Mumbuno Molambo, he is a lecturer in the Department of Medicine at University of Zambia and head of gastroenterology at the University Teaching Hospital, which is the biggest referral center in Lusaka, Zambia. He's involved in clinical care, medical education, and research in gastroenterology. and was awarded the prestigious IOIBD Exchange Fellowship Program at AIIMS New Delhi, which he completed for further advanced training and exposure in inflammatory bowel disease. Welcome, Dr. Malambo.
Thank you very much. Apologies. The link I'd used didn't give me a chance to talk, so I've been following the talk. I think our situation is also like Dr. Kwado has said. Unfortunately, we don't have access to P19 or P40 original or biosimilars. So the highest we get now are small molecules. So we find it easier to get drugs such as TOFA and UPA because the people in rheumatology have been using them for some time. And for us, they cost almost the same as AZA. So when escalating, we prefer to use TOFA, which is way cheaper for us than anti-TNF. Anti-TNF cost almost $150 per 100 milligrams in an economy where the average salary is $400. It's quite challenging. So only patients that are able to buy on themselves. The government system unfortunately does not procure anti-TNFs. So even for P19 and P40 originals, unfortunately, we're not able to have at the moment. Thank you.
Thank you for providing that insight. One of the questions that I want to ask, again, this is to all the panel. If you can push for one P19 therapy in your country, which P19 therapy would you prefer and why?
Okay, so you are referring to choose just one for both diseases, or I could choose one for UC and another for CD, because that would be my choice. If I could, I would choose.
Okay.
I would choose risankizumab for CD because I have a much more stronger body of evidence. We have Advance, Motivate, we have strong clinical data right now, and we also have some real world data that are quite, I would say, reassuring that risankizumab is a very good choice for CD. For UC, on the other hand, most of the evidence is regarding mirikizumab, right? At least from what I have been able to read, we have more data on mirikizumab and also real world data already starting to appear. So that would be my two choices.
That's nice, Maria. You are very data-driven, and that's excellent. For me, I'm just going to be a bit more pragmatic. And I know that guselkumab is getting pushed hard, to get through the PBAC and BPBS approved. So whatever I can get my hands on, I'm going to say yes, please. So I'd be very happy to have any of them, to be honest. If guselkumab is the closest to get, above the line, over the line, I'd be happy to endorse it. But yeah, I do agree with your insights as well.
Dr. Boat and Dr. Mabuno and Malambo, I know that there are so many pipeline drugs before you get to P19, unfortunately. I guess maybe the question for you is, what will it take for any new drug to arrive to your country?
Okay, so we had some pharmaceutical companies who contacted us who wanted to introduce biosimilars for the various classes of medications. So they were trying to do a sort of a pilot to see where we are in terms of cost and what cost category will be that patients may be able to afford, because I think in our setting, the main issue is affordability of the medicines, because even with available medications, as with unlimited access, still cost is the major barrier. So they did this feasibility with all the gastroenterologists to see what cost bracket would so they were looking at percentage of patients who be able to afford. So that was like last year. So we are hoping that probably maybe this year or maybe the next, we may have some biosimilars of these medications available. What we have available is still the innovator brands. So we are still using the Actimera for the infliximab. So hopefully with the biosimilars, then the cost will come down, then probably we can put more of our patients on these medications. Thank you.
So for us, our only hope is the government has come up with a national health insurance scheme. So they usually ask specialists for what drugs they can procure, but they usually work with numbers. So for us to be able to get some advanced therapy, we likely have to work with people from dermatology and rheumatology. And we're hoping by next year we'll have infliximab and adalimumab on the government system. And then from there, we'll see what we can build up on. Because for you to get the numbers, like for us, IBD, in my clinic, maybe I have 150 patients. So that's not enough to convince the government to invest in one drug. But if I were to add other departments and other hospitals, it gets us more to 1,000 of patients. So currently, that's the advocacy that we are going with to get anti-TNFs on the government program. Then maybe in future, with need to escalate dosages, we'll move to more advanced therapies than anti-TNFs. For now, it's quite a challenge.
I see. And are you
Thank you.
noticing that IBD is increasing in your countries? Because we're seeing it in places like the Middle East and India and Pakistan.
Yeah, so IBD is increasing, but what is shockingly is we don't have aggressive disease like the disease I would see in New Delhi. So unless in children, that's why we see very aggressive disease. But in adults, not as aggressive, because in the past, like 2 months, in the past 6 months, we've only admitted 2 patients for ASUC, and these patients still did very well and went back home without any surgery. Maybe in the last 2 years, we haven't done any colectomy for UC or any IBD intended surgeries, but so not sure why we have a less aggressive disease. And this could be the reason why maybe we're not getting that much attention from the policymakers.
Good to know. And just for reference, a biosimilar infliximab in USA, 100 milligram vial costs about $500. So the market down to $150 in probably both your countries. It's interesting to see how pharmaceutical companies try to help locally, or how like each country, depending on what the cost of living and everything else, the price of the same drug changes. So it'll be interesting to see how much the markdown of the newer drugs will be. I think you have one more question, right?
Yeah, so I think I want to ask this is also for the entire panel, is one myth about the biosimilars that you would wish would disappear in IBD.
So may I start?
Yes, please go ahead.
So first of all, what I always try to say to my patients is that biosimilars have very strong data that supports that they are useful. So I think that it's essential that we, as physicians and also nurses and all people that have patients in front of us, transmit them that these decisions are just not because of money. Of course, money is like what decides several things, but there is data that supports their utility. It's something that I always say. And for example, here in Portugal, it's not, well, it's a decision of the hospital that all patients that were taking Stelara will change to the biosimilar. It's not something I can control, you know. So it's essential that me, as their physician, have this conversation and explain this to them. So I think that's important. And also we know, for example, as we see with infliximab, that there are some biosimilars that are indeed very good drugs and can be even a bit different in terms of PK and efficacy and all that. So I think the myth is that they, just because they are cheaper, they won't work. So I think that's something. Yeah.
All right, well, those are all the questions I have. Let's see if we have any questions from the audience. Otherwise, I'll give it back to Joseph.
Arun, do we have any questions from the audience that you can send to us? Okay, so we have a question from Anurag from India. Wonderful summary. What about the drug persistence of ustekinumab versus risankizumab? The sequence study showed higher percentage of patients who completed therapy in risankizumab group than the ustekinumab group. Would anyone like to take that? So I guess it's a question more about whether the study was a truly good comparator study and whether there were some flaws in the design, which Rana talked about a little bit. Manuela, I see yourself unmute.
So yeah, that's true. That's the truth is that all the trials that we have that look to P19, they are very different among them. They all have little flaws that make us the comparison between them is very difficult. In this case in particular, it seems to be true that Risa had a longer persistence of treatment, and I think it will be very interesting to analyze, for example, patients that are intensified. If you look to the money that we would save by using the P19, probably that would be an interesting analysis to make. But as far as I know, we don't have that data. So the data that we have here from sequence, I think the study is not powered to say this, but it seems to be a tendency, I think. Yeah. Probably because of higher efficacy.
Great. And Jorge Rodriguez from Buenos Aires, Argentina, welcome, was asking about the indication in patients who have previously failed previous treatment and now have an anal fistula. I don't know which previous treatments have had non-response, but let's assume it's already an TNF and the vedolizumab. What would your next therapy be? Would it be a JAK inhibitor, a P40, or P19 with an anal fistula? And this is one. Two, if it is an underlying hematological disease, and I don't know specifically if it's active or history of hematological disease. Patricia, I see you on mute.
Yeah, look, I don't exactly understand the question as well, but when we say who failed previous therapies for a active anal fistula, what are those therapies? If we are assuming the standard, therapies for a fistulizing Crohn's disease, which is in terms of biological therapy, is a TNF alpha with optimal, doses and optimal trough levels. And I mean, very important as well to know what kind of perianal disease we have as this patient undergone in MDT. This is very important for perianal disease. A surgical assessment, a good EUA and clean, and if they need ceton and reepithelialization, because all of this assists our biological therapy. So it's a difficult question. I don't have the accurate scenario for the question. And moving forward, I think the signals we have for perianal disease, apart from the TNF alpha blockers, is weak. Yes, I've had patients, with resistant disease on ustekinumab. I've actually tried people on upadacitinib. We're really awaiting the fusion trial results to see what the guselkumab can give us. But it's again a case by case. And we had patients where we had to do a diversion, a stoma, a colostomy to try and decrease the rectal inflammation if there is persistent rectal inflammation driving the fistulization. So it's a very difficult question. If, perhaps, you can tell me a bit more, I might be able to answer better. But again, perianal disease is one of the hardest things to treat in IBD. I always do it in MDT, good radiological review, a good EUA as needed, and good level of therapy, combination therapy as well with immunomodulators.
I think I'll simplify it because Jorge, we haven't seen back a response. I'll simplify it and say that the MDT has been done, the ceton has been placed, infliximab and vedolizumab have been tried, and this is the right person to try something. They have anal disease and a fistula. So we know a therapy is going to be needed. Currently, I understand UPA has some small cohort. Riza perhaps has some small cohort. Ustekinumab we've seen with dose intensification has is a potential answer. If you had all three, could you choose one, or you just ask the patient if they prefer a pill or a sub-Q?
Well, I do, and I do as well, depends on the patient profile. If they have contraindications for a certain therapy, if they have another extraintestinal manifestation. I don't really favor one of them over the other. I don't have head-to-head trials, the signal is weak for all of them. So it depends on the patient scenario and the patient case. I'll, speak to them. I'll try and see how we go.
I'm going to complicate the question a little bit more. I think maybe they're asking about the hematological disease is a venous thromboembolism disease or a coagulation disorder. So that complicates things a little bit more in terms of what we're going to use or choose.
Or maybe simplify things and, perhaps put JAK inhibitors out. It depends really, but, put JAK inhibitors out of the question. Is depends on which type of DVT provoked, but usually I try to avoid it. So yes, this is one option out if this is a hematological disease that's underlying, if it's a, procoagulopathy that patient has or a factor V Leiden, etc. I'd be very hesitant to put them on a JAK.
Great. Any parting words from Rana, Siddharth?
Yeah, this has been great. And thank you, Joseph, and the whole Yogi IB team. Thank you for the experts and very remarkable insights, particularly from our colleagues from Africa. Yeah, I thought we had it worse in India, but actually situations are actually a little bit better. Hope you guys get vedolizumab and P40 and P90s in the future. Thank you so much.
Yeah. Thank you, everyone. And it's very nice to have insights. Yes. Oh, sorry, Hugo.
Before we log off, I want to thank everybody for the time and the energy spent putting together these phenomenal talks. And I know that everybody's logging in from different part of the world with different time zone. And so thank you for staying late at night or early morning with us. This was so insightful, really highlighting the difference in terms of challenges in accessing different therapies and how different therapies are using in different parts of the world. And I hope this is just the beginning of these kind of conversation to learn from each other, but also really have an appreciation of those who are clinician managing patients with IBD with limited resources and still doing it with such a care and devotion. So thank you, everybody. It was really, really very interesting conversation.
Thank you, everybody. I'll end the presentation with just the website of Yogi IBD in case our viewers have not seen the website yet. It's youngibd.org. It will hopefully be there's a registration site for any future events, and we are welcoming all collaborations for education and hopefully in the future research. So with that, thank you, everyone. Really, this was terrific. I can't thank you enough for making this as a successful global educational series. And with that, thank you so much for joining us.
Thank you, Joseph.
Thank you. It was a pleasure.
Thank you so much. Have a
Thank
good
you
rest of
for
the day.
having us.
Thank you. It was really wonderful. I learned a lot, and it was fun to see faces that are new and faces that I've seen in the past. So if you're ever around USA, or if we're around in your countries, we will let you know. And really, we're growing, and we want to do this international education at least. But hopefully in the future, there's more opportunity for collaborative research as well. Okay. Well, take care, everyone, and have a great rest of your day. Patricia, you can go back to sleep now.